So today, as the introduction has happened, like I'm going to discuss regarding CheckMate 816. Immunotherapy is making its way into neoadjuvant as well, and we have seen in breast. Now we have seen in lung as well. So today I'm going to discuss the phase 3 trial, which analyzes the surgical outcomes by adding nivolumab to the platinum doublet versus platinum doublet alone as a neoadjuvant strategy for treatment of resectable non-small cell lung cancer. So why NACT? So NACT, as per the meta-analysis from stage 1B to 3A, we all know there is a good benefit. As the stage increases, there is a good benefit by adding NACT. And also preclinical studies, I'm just like giving the extrapolation for the immunotherapy. The antigen presenting cells are needed so that tumor cells can be recognized by host T cells. And hence, when the tumor load is large, APC bears a large antigen load to elicit a stronger anti-tumor T cell response. So these are the phase 2 studies, various phase 2 studies we have seen till now. And Dr. Bhavesh is going to update regarding NADIM study. So if you see, the maximum pathological response rates are like quite promising to see the phase 2 studies. And it has shown there is no safety signal, all are quite promising with a good tolerability. So what is the current role for perioperative systemic therapies in the early stage, that is stage 1B to 3A, as already discussed. So how we are going to improve the outcome? Here we go. So what is the inclusion criteria and what is the outcome? Like we will discuss soon. So the inclusion criteria is stage 1B to 3A without any EGFR or ALK mutations in the lung cancer with the preserved performance status. The PDL1, it got stratified by the stage basis, that is 1B2 versus 3A. And PDL1 more than 1% versus less than 1% and sex. So the patients got randomized to two arms. That's Nivo 360 mg Q3 weekly plus chemotherapy Q3 weekly versus chemotherapy alone. Here in non-small cell, we all know the squamous will have a different regimen and adeno will have a different regimen. Adeno, PEMSIS, paclicarbo is fine, whereas squamous, GemCis, paclicarbo is fine. Sometimes some patients receive WinCis also in the chemotherapy alone arm and GemCis as well. So that's how the randomization happened, though the chemotherapy, like few additional happens in the chemotherapy, but it was well balanced. So after 3 cycles, the patient was taken for surgery within 6 weeks of post-treatment. Later, optional adjuvant chemo plus or minus RT was given for by follow-up. The primary endpoints is pathological complete response. Key secondary endpoints were overall survival and maximum pathological response. The key exploratory endpoints is overall response rate. The methods, as already discussed, PATS-CR, and just these are definitions. PATS-CR is like 0% residual viable cells, and maximum pathological response is less than 10% of the residual viable cells. So the exploratory endpoint, the ctDNA levels also they have done. So they analyze in the baseline and later they serially followed up during the treatment as well as completion of the treatment. So we all know this is a very good translational medicine entity, ctDNA monitoring the treatment. So it allows us to understand the tumor burden in the body. So the baseline characteristics were very well matched. As already discussed, the stage stratification, histology stratification, smoking, beta sex, tumor PD-L1 expression, tumor mutation burden, everything is very well balanced in the both arms. If you see, these results are very promising. If you see the first, the pathological response, the PATS-CR as well as maximum pathological response, if you see both, there is a hell and heaven difference between the combination versus chemotherapy. That is 2.2% versus 24%. It's nearly 21.6%. Whereas in maximum pathological response, it is 8.9% versus 36.9%. So significant improvement in pathological complete response and maximum pathological response is noted. This is the treatment and strategy. Both arms like completed a treatment very well, but if you see the nivolumab plus chemotherapy, they completed the treatment quite well. And the type of surgeries are also very well balanced, but the maximum resection happened again in the chemo plus immunotherapy arm. The R0 resection rates were slightly higher as well. So the patient like who canceled definitive surgery, either PD or AE, it is less in the Nivo plus chemotherapy arm. And coming to the pathological CRS by central review, and again in intention population, there is significant difference between the combination versus chemotherapy arm. The patients with resection, if you see already discussed before, there's a significantly higher resection is noted. Coming to the subgroup analysis, if you see, all favored nivolumab plus chemotherapy, be it the stage-wise or PD-L1 expression-wise. Even the less than 1% patients also got benefited by addition. but though it is like not so significant, but still the benefit is there by addition. All are falling towards combination. Not even single line has crossed the midline to favoring the chemotherapy. So coming to the overall response rate, again, if you see chemotherapy versus combination, there is a significant difference in the percentage of the patients who got benefited. There is a significant radiological downstaging happened with the combination. And the baseline is the beginning itself I mentioned. If the antibody tumor burden is like, if the tumor burden is high, the antibody load will be very high. So antigen, by the release of increase in antigen levels, there will be increase in production of antibodies. So it's always better to introduce chemotherapy plus combination of chemotherapy and immunotherapy at the beginning itself. If you see the treatment and adverse events, there is no significant safety signals as of noted, though there is slightly like, in fact, like there is a slightly higher nausea than chemotherapy. There is an increase in anorexia and chemotherapy arm. There is, as such, there is no difference in the side effect profile. So what are the ongoing phase 3 trials? Like, apart from 816, it is Keynote 671, Empower 030, AGAN, and CHECKMATE 771. So apart from the Nivo, pembrolizumab, atezolizumab, durvalizumab, it's making its way to introduce the neoadjuvant therapy of lung cancer. The summary of CHECKMATE 816. CHECKMATE 816 met its primary endpoint of pathological complete response with additional nivolumab to neoadjuvant chemotherapy for newly diagnosed resectable stage 1B to 3A. The pathological complete response benefit consistent across all analyzed groups. We saw the beautiful forest plot. The maximum pathological response and overall response rate also improved. The data is still immature to analyze the co-primary endpoint, that is EFS. Exploratory subset analysis observed that ctDNA clearance more frequent Nivo plus CT versus chemotherapy and was associated with pathological CR. Neoadjuvant nivolumab plus chemotherapy demonstrated a tolerable safety profile without adversely affecting feasibility of surgery. CHECKMATE 816 is the first phase 3 trial demonstrating benefit of neoadjuvant immunotherapy plus chemotherapy for resectable non-small cell lung cancer. Thank you, organizers. I'm happy to take any questions or comments.